Indeed, I consider this the most important of my 3 talks. So if we go over time, I will skip my foreign body lecture because this is not as important as this one. So first of all, you have to realize that in life you have choices.
我台里明明老师，我咧落針，一百個咧做後生咧跳啊！我台咧。咧明叫我咧唔會學那硬魔咧背。做咩學跳魔嘅歌？學呢？我係做聲聲聲就話。面計黃虎啊！
So these choices are true for corneal suturing as well. Remember what I said, half of these eyes will require posterior segment surgery. So you have to do your surgery as early as possible. But in the phaco era, nobody teaches corneal suturing anymore. Really. I go to all kinds of institutions and I ask them, do you teach residents, fellows, how to do corneal suturing? I said, no. Because it is not random introduction of sutures in the cornea until you say, okay, now it's a watertight wound, but you have to plan what you do. This is what happens if you don't plan, and this is what happens if you don't plan in the cornea. So before you start suturing, one question is how soon you should suture. This is an example of what happens if you don't suture on time. This is a very small corneal wound, 1.5 millimeters, but nobody wanted to suture it, and by the time the suture is put in, the patient already has endophthalmitis. Just want to tell you again, there is no forceps in the image. The material, of course, is tenonylon, and the needle we choose is so-called spatulated needle. But if you look at that needle, you will realize it is not spatulated. It's a combination of round and spatulated. And you have to know that if you catch this needle with your needle holder at the round part, it's going to turn. So make sure that where you grab is in the truly spatulated part. Wound toilet, I don't want to talk about it too much. I repeat what I said, don't excise the iris unless it's contaminated. But take it out from the wound, and how do you do that? You create a paracentesis at least 90 degrees away. Never push iris tissue back into the anterior chamber. Always pull it from behind by a sweeping motion. Viscoelastic. I don't have time to go into this, but I want to tell you this. Do not use viscoelastic unless absolutely necessary. Why? Because when you do that, you tend to put too much viscoelastic inside, and that means that your wound, which was, or the cornea, which was like this before, will be like this now, and therefore, when you put in your suture, you are going to fight the viscoelastic. Now, how can you don't use viscoelastic? Because when you see the patient, in almost every case, the anterior chamber is already formed. And if you need viscoelastic, it's because you lost aqueous. How do you lose aqueous? One way to lose aqueous is to use forceps. So this is the typical example. A lot of viscoelastic there. This is a teaching video from one of the most famous ophthalmology institutes in the world. And you can see the flap of the cornea does this. How do sutures work? They do work by tissue compression. And the compression is a zone. You put in your suture, and then it has maximum effect in the plane of the suture, and as you go away from it, the effect goes down. And how do you create a watertight wound? Is you have overlap between the compression zones of two neighboring sutures. If they do not overlap, you have gaping. How do you deal with the gaping? You don't create gaping. You plan where you put your suture. You plan how wide the suture or long the suture is, and therefore you will not have gaping. At a given tension on the suture, the longer the bite, the longer the compression zone. That's why you don't use tiny sutures. You use typically longer sutures. I will come back to that. What types of suture? There are two types, interrupted and running. Which one to use in the cornea? The rule is very simple. Long peripheral limbus parallel wound, that's where you use a running suture. Everywhere else, you don't. So if you look at that image, you never do that. Why? Somebody already showed it, because a running suture will flatten the cornea. You don't want a flat cornea. You want the dome shape of the cornea to be maintained so that you have a deep anterior chamber. So no running suture except in the limbus. Let's talk about forceps. So in every other tissue or case on the human body, how do you suture a tissue? You have two things in your hand. One holds the needle holder. I'm a right-handed person, so this is needle holder. And the other hand has a needle, a forceps. Why? Because when you enter the tissue with your needle, it tends to push the tissue away. Depending on how good the needle is, and especially how massive, how strong, how thick the tissue is, it changes, but still it gets pushed away. So what your forceps does, it counteracts that. So needle comes from here, your other hand holds the tissue against it. But in the cornea, you don't need to do that. Why? One, the needle is extremely sharp, both the tip and the side. It will cut through the tissue easily. The second is you don't grab, so there is no need to grab the tissue because the cornea is soft, and again the needle will go in it very easily. Additional reasons not to do that is because it traumatizes the cornea. And traumatizing the cornea means you increase your enemy, which is edema. And as I said, you lift the tissue with your forceps, and then you lose aqueous, and now you have to use viscoelastic, and now you have to fight the viscoelastic. So this is the typical example. You grab the cornea and you put your suture in. This is a 25-year-old video. I had to resuture this cornea, and you can see I'm at the limbus, and still there is no need to use forceps. I will come back to this again later on. Now let's talk about the order of placing the sutures. Typically in the body, and that's true for most scleral wounds as well, you have the tissue. So the 50% rule. Your first suture is in the middle. Now you divided the wound into two. and then you continue dividing it in equal length halves. This is what you typically do. You don't do that in the cornea. As you heard before, there are specific features, landmarks to look for. One, limbus. If your wound is corneal scleral, your first suture is in the limbus. Why? Because this is where you see where cornea is against cornea and not cornea is against sclera. The second, I'm sorry, here is a video of it, so you do this. The second one, you heard it in a talk already or twice, angle. I remember when I had to do such a corneal suturing when I was young, and of course nobody told me that this is what you do. Your first suture, as you see, is at the angle. So I did not do that because I said to myself, if you have a sausage, you don't start in the middle. You start the sausage eating from one end to the other. So that's what I did. What happens if you do that? What happens is this, so this part of the mobile part of the wound, can you see that? If you start your suturing from here and go here, by the time you get to the middle, this part will move. And now, if you want to close the wound, you can still close it, but you have to have a lot of strength, tension on your suture, which means your cornea will be distorted. And that distortion is permanent. Even if you removed your suture, it remains. You start there, just like in this case. It's not my video, obviously, because I don't use the forceps, but the location of the suture is correct. You go through the angle, come out on the other side, and now you have two simple wounds to close, which are easily done. But what if you have this, and it's not that rare, that you have a transcorneal wound from 9 to 3. The technique was developed by these two gentlemen, Rosie Hayes technique. So what you do is, again, not 50% rule, but you start where? At the two edges of the sausage. And your first sutures will be very long. Why? So the best way to explain this is you take a rubber ball and you cut it in half and you put it on the ground, and then you take your 4 fingers and you compress the ball on the two sides close to the ground. What it does, it is going to increase the middle apex, the corneal center, by doing that, and that's what you want. Again, you want to avoid a flat anterior chamber. If you do this, you are going to increase or at least maintain the depth of the anterior chamber. And so you come and eat the sausage from the two ends, coming towards the center. So that's first rule. The second rule, the closer you are to the center, the shorter your bites will be. So this is what you do. And you avoid the epicenter. Why? You should never put a suture in the epicenter. Why? Very simple. If you look at a cornea where the sutures have been removed, the scars, which are not or barely transparent, will form not only where the wound was, but along your suture tracks as well. So you don't want to put a suture in the epicenter. And so this is how a transcorneal wound should be after you sutured it. Now, this explains what I said. If you do this kind of suturing, you will not full thickness, I come back to that. You will not have a problem continuing and doing all your posterior segment work because your cornea is clear. And one thing to notice from this, how few sutures you need to close that cornea. If you look at most corneas that have been sutured, you would have twice as many much smaller sutures. So what if you don't do this? You do not use the rosy haze technique. I took these two next images from a textbook, and it was not among the bad examples in the textbook. The green curved line shows you what you want at the end of the cornea, but if you do this on the left-hand side or the right-hand side, then your cornea will not have a dome shape, it will be flat. So now let's talk about the other very crucial difference other than the forceps, is how deep your bite should be. Again, traditionally, they tell you it has to be 90%. So what's wrong with that? And my short answer is everything is wrong with that. Why? First of all, how do you know you are 90% deep? You are sitting above the cornea. You're not inside or underneath the cornea. You have no idea whether you are 90%, 85%, or 99%, or 100. You don't know. If you really want to know, what do you do? Because there is a possibility to know it, and this is what happens. You take your forceps, you put your suture in, and then you lift the cornea, and then you look. What does it do? You lose aqueous. Now you go and use viscoelastic. And it's true whether you're entering or exiting the cornea. But if you do not want to look, and remember, ideally, your movement of needle entry into the cornea is one movement. So you take your needle holder and you do this. And if you do that, again, you have no idea how deep you are. The second problem is the thickness of the cornea on the two sides is never the same. One is always a little more edematous than the other. Therefore, on one side you may be 90 degrees, but on the other it can be anything. That is a permanent distortion again. But the biggest problem, I'm sorry about the number, but on my computer it was at the right place, here it's not. So, this is the biggest problem. So look at the cornea on a cross-section. What you did was this. You closed, let's say, 90% depth, but you left 10% open. That 10% is in water. So aqueous is able to enter your corneal stroma non-stop until it closes. And there is a solution to this. What you do is you stop the fluid from coming by closing that posterior 10%. No fluid entering anymore. Because your suture is in the anterior chamber, you close the back as well as the front part of the cornea. So look at this image. This is a lady who lives in a farm far away from everything. She has no phone. She is cleaning the cage of the chicken, and one of the wires punctures her cornea. For 3 days, she's alone. She doesn't see anymore because she has endophthalmitis. And the 4th day, the son comes and says, "Mom, what's wrong with your eye?" And now, on the 4th day, she is taken to the hospital, and this is the image I'm showing you. I see when I do the surgery. You can see the cornea. You can see how much I see of the retina, because obviously I continued her surgery with vitrectomy. She has endophthalmitis. Very poor view. I've sutured the cornea. You can see the sutures here with full thickness sutures. 16 hours after this is the image. This is what happens if you close the cornea completely, full thickness. Edema disappears. So what arguments do you have against full thickness sutures? There are several. You heard one already. I'm not going to talk about the rest because of the time, but this is the most important one. The risk of endophthalmitis. Question, is it true or not? Especially knowing that the track, the channel that your needle cuts in the cornea is larger than the thread, the suture material that is inside. It seems logical that there is an opening, a channel connecting the outside world with the anterior chamber. Is it true? That is true. However, you already have edema in your cornea, and that edema will instantly compress that channel. It closes the channel. How do you know that? I told you, never believe anybody. You have to know that it's true. And one way to know that is to put a little compression on the cornea and to see if aqueous leaks along the suture tracks, and the answer is no, they will not. But there is another way to know that, and this has importance for you for the technique of burying the knot. When you see me closing a corneal wound, I put my suture in, I do the knot, and I cut it immediately. Why? Because most surgeons, you will see, to save time, they will cut it at the very end. And they will have struggle burying the knot because the channel is already closed. So now they have to force it to be open again. So very simple, bury the knot immediately after you put it in. But this has significant full thickness suture. So no risk of endophthalmitis postoperatively, but there is a risk when you remove the suture. Because when you remove the suture, you lift it, you cut it, and when you pull, part of it, what was outside, is going to turn into the anterior chamber. So sterilize the surface the same way as you do for an intraocular injection. Length of the bite should be equal on two sides. Very simple rule. If you don't, you have a distortion. Again, this is permanent. Angle, 90 degrees. If you don't, the tissues will shift because that's what what the suture forces the tissue to do. And again, this is not going to disappear by suture removal. How do you do the knot construction? Several ways. I will tell you what I do. I will tell you how I do it. I will tell you why I do it. The first is a triple throw. So you do this, and then I saw one of the videos, beautiful, exactly how it should be. Then you cross your hands. If you don't cross your hands, you create a sphere, and your knot will be bigger, more difficult to bury. And then you tighten it. Don't make it tight with this technique. Just barely leave the thread lie on the corneal surface, because you will tighten it with the next one, which is a single throw, and notice that your angle changed 90 degrees. Why? Because this locks the knot. it will never get loose after this one. And because you left the first triple throw loose, this is how you can tighten it without tightening it too much, because you see what happens to the cornea. And then you repeat that, a single throw as a third one, just to be on the safe side. And again, you turn your hand 90 degrees. So the third one is parallel to the first one. So this is the technique. Again, no need to have forceps. You come out on the other side. If it does not want to come out, then you grab the conjunctiva. If it happens over the cornea, you simply put your forceps onto the surface so that the needle will come through the jaws of the forceps. And then you do a triple throw. And notice again that your hand has to move to the other side. So 1, 2, 3. And now you change and let it sit there loose. Single one, turn your hands 90 degrees. This now tightened it. A third single one, again turn 90 degrees. Now how do you cut it is the next issue. Because typically the nurse will give you scissors. I will show you on the last video that I prefer not to use scissors, and I will explain why. So bury the knot. This is an absolute rule, and yet you see, I see, corneals sutured like that when the surgeon could not bury the knot, probably because either the knot is too big or does it at the end of the suturing rather than after each suture. Which direction? If it doesn't work in one direction, go and use the other one. There's no rule which way you have to turn it. But it has to be buried immediately. So, this is a summary. It's a fresh wound. You can count how many sutures are used. I will show you. The first thing you do in this case is to remove every suture, because this was done without planning. Just put in sutures, even different kinds of sutures. And this is, you can see, this is an angled wound. So obviously, you go through the angle. This is more difficult than normal because you had to remove all the sutures and you lost some aqueous, but I still don't need viscoelastic. So you come out on the other side. We are very close to the end. And you put the same, let's see if I can fast forward this a little bit. So you tie the knot. Turn your hand. So, I will explain to you the blade after, because I don't want to interfere with the video. So, you put that suture in, and then you put additional sutures in. Now you start from the limbus again, because this wound is, the edges are close. So you want to maintain, as I said, the depth of the cornea, the anterior chamber. So you go from the two edges, wound edges, towards the center. And you repeat it from the other side. I did not remove the other suture, which on the video is at 6 o'clock, because that's not critical, although it's not an acceptable one. But this is how many sutures you needed, and this is how many you had. Remember, as I said, you have a scar along the suture track as well. So before, let me explain to you why it's more optimal to use blade to cut the suture and not scissors. So imagine yourself sitting over the cornea. Then here is the suture in the forceps, and now the nurse gives you the scissors. You put it down, and once you put it down, the scissors covers where the knot is, because the scissors is thick. So you don't know exactly where you cut it. So a more controlled way of cutting it is the blade. So what do? You hold up the suture one by one, and you place your blade right on top of the knot. And then you move your suture to the blade and not the blade to the suture. That way you cut it exactly where you want it, and then bury it. Okay, any questions?
Sir,
I'm sorry. Let me add one more thing. So I have been preaching this for 25 years. And I often go to meetings, and because people argue with me, don't do 100% because of this or that. But most people will at least try. So I had a lot of people coming to me years after I talked about it and said, I tried it, and indeed it makes a gigantic difference. The edema is gone when you are finished suturing. So it's much better for the patient visually, and much better for you, because not only can you do, as I said, everything that you need to do in the posterior segment, but also you can follow what happens inside the eye postoperatively. Yes. Yes.
Just wanted to ask one small question. You have wonderfully sutured the corneal wound, but on the first or second day, one or two sutures are loose, or maybe in the form of loop. You immediately remove it?
Well, it really shouldn't be. If you use this technique, you will not have loose sutures postoperatively, whether it's day 2 or many days, except in children. In children, the cornea is more elastic, and the sutures will become loose much faster. So for this reason, and also because healing is faster, the removal, I did not talk about it obviously, the removal time in children is much shorter for the same wound length than in adults. But as a general rule, the answer is, if you do have a loose suture, yes, remove it, because the loose suture will increase irritation, inflammation, vascularization.